Speaking about Ed Benzel, I don't think we need to say a lot because everybody knows Ed Benzel, and everybody knows that Ed Benzel is great. And so we are expecting now a great presentation on cervical spondylotic myelopathy and deformity. Ed will talk about his journey. Ed, please share your slides.
Well, now I have to live up to that.
It's not going to be very, very difficult for you, I'm sure.
Okay, I'm going to talk about biomechanics and my journey through that a bit, and then my journey through my clinical experiences, predominantly associated with deformity and myelopathy in patients with cervical spondylotic myelopathy. I have a disclosure that it has nothing to do with spine surgery. I'm going to initially talk about biomechanics of spinal column failure. This is the fundamental equation of spine biomechanics. Bending moment is the product of the force applied times the distance from an axis of rotation at which the force was applied. So a force applied at a distance d from an axis of rotation, we call it the instantaneous axis of rotation because it changes with time and motion, is the bending moment. Bending moments cause concentration of stresses. In this case, it initially caused the concentration of stresses ventrally, which initiated failure and then propagated dorsally. All points ventral to the IAR came closer together, and all points dorsal became farther apart. So if we instrument the spine, we're basically trying to prevent or correct deformity. And Archimedes stated, "Give me a lever long enough and a fulcrum on which to place it, and I shall move the world." And theoretically, at least, this is the case. We work around the X, Y, and Z axes of the Cartesian coordinate system. Again, this would be the center of the system. A force applied at a distance d creates a bending moment, which is the product of the force times distance, which causes a concentration of stresses. So we can prevent or correct deformity by 6 fundamental mechanisms. One is distraction. If we distract in the inner body region, we do not create a bending moment because we're distracting in the region of the instantaneous of rotation, axis of rotation. However, if we distract, for example, farther dorsally, we might cause a ventral bending moment. 3-point bending is another type of fixation, which is present when there are 3 or more fixation sites along the long axis of the spine. And in this case, there is a downward force at both ends and an upward force, which is equal to the sum of the 2 downward forces in the middle. We can use that obviously as a lever to correct deformity. We can also compress the spine. There are a variety of ways of doing that, including wires or clamps, etc. And then there are 3 types of cantilevers. A cantilever is a beam that is affixed to an immobile object at one end only. If it's rigidly affixed, like a screw that is rigidly affixed to a rod, we call it a fixed moment arm cantilever beam. But a beam could also be affixed to an immobile object by way of a hinge or a screw that toggles. It's still a beam, but we'll call this a non-fixed moment arm cantilever beam. And then we can apply bending moments with shank screws or cast bar pins, and we'll call that that type of a beam a fixed, an applied bending moment beam. The failure can occur in the spine by many mechanisms. Let's just talk about several of them. If I push in the middle of a tin can, it will dent in. If I push on the edge of the can, it is much more rigid. This is called the boundary effect. And hence, we may want to consider placing interbody struts or grafts or cages more towards the perimeter rather than the central portion of the end plate, taking advantage of the boundary effect. Screws fracture in interesting ways. This is a fractured screw at its base, and this is a screw that fractured near its tip. We might ask the question, why did that happen? And it gets back to some fundamental principles of biomechanics that have to do with section modulus. For one, section modulus, or zeta, is equal to the third power of the inner diameter of a screw, or the diameter of a rod. It basically tells us how much strength the system has. Theta, or stress, is equal to the bending moment over strength, or section modulus. Implants always fracture at the point of maximum stress application. So this is a very important equation. So this implant fractures at a point where there is very little metal and a relatively long bending moment. And henceforth, the screw fracture occurs at this point. Additional factors that may have played a role is that this implant was bent prior to insertion in order to conform to the patient's contour of the spine. And when we bend a plate, it's going to predominantly bend where there is less metal or where the section modulus is diminished. And in those circumstances, it may have caused a stress riser that additionally led to this plate fracture. So why did this screw fracture and this screw fracture at the points where they did? Let's first take this screw. This is a fixed moment arm cantilever beam with a constant inner diameter screw. And so if we apply a force to the screw, the bending moment rises until we get to the plate. Since the inner diameter of the screw is constant, the stress also rises linearly and is maximum at the plate. So the stress, the denominator of this equation did not change as we go across the screw, and so the stress is maximum at this point. So this is a different scenario. This screw has a tapered inner diameter. And so the section the bending moment still increases linearly as we go along the screw. But also as we go along the screw, since the section modulus is proportional to the third power of the diameter, the section modulus increases exponentially as we pass along the screw. And henceforth, if you look at the mathematics associated with this, where the numerator is increasing linearly and the denominator is increasing exponentially, we see the stress being maximum at a point somewhere near the tip of the screw, hence the fracture of the screw near its tip. Screws that toggle, or non-fixed moment arm cantilever beams, are usually fixed inner diameter screws, and they can windshield wiper through bone, and that can provide in a sense, a form of dynamism, which allows bone to see bone healing enhancing forces. Here's another example of non-fixed moment arm cantilever beam screws in a mid-generation cast bar plate where the patient actually went on to fusion. And you say, well, how can that be when all these screws fractured? Well, let's look at the situation. When this spine subsided, the screws were exposed to 3-point bending forces. And so screws that were in a hole in this implant were fractured because of these significant forces. So here's the AP view of this implant. On one side is a slot. On the other side are holes. Slot, holes, slot, holes, so on and so forth. All the screws in slots held, essentially, allowing the spine to subside along the axis designed by the surgeon by the contour, by virtue of the contour of the plate. And the screws in the holes were exposed to 3-point bending stresses and henceforth fractured or backed out. Here's another example of that, a much simpler example. So implants function differently under differing loading conditions. I asked the question, nobody really has to answer this because I will answer it in a bit. Is there such a thing as a ventral compression implant in the cervical spine? The answer is yes, but in a way that you might not think of it. We know that we can compress from behind, but the question is, can we compress from in front? So if we compress from behind, we can use clamps or wires or a variety of strategies to compress the spine, but we really don't have a mechanism to do it in front unless you consider this. This is a fixed moment arm cantilever beam. In compression, when the spine is exposed to compression, this implant resists by distraction. So it's a distraction implant. It also is a cantilever beam. But when the patient attempts to extend his or her neck, this device actually resists that and henceforth is functioning as a compression device. And the only reason I'm bringing this up is because we need to be thinking of all the ways in which an implant or construct can fail and then act accordingly to prevent that. So this device then, in extension, acts as a compression device. So we have distraction, tension band fixation, 3-point bending, and cantilevers are loading modes. What is missing here is an intermediate point of fixation, so we don't have 3-point bending. This is a bridging implant with a high failure rate associated with multiple corpectomies, fibular strut, and then the bridging implant. You might say it fails because it doesn't resist axial loads very well. Well, that's probably not true. It relatively effectively resists axial loads, but what it doesn't resist is translation or rotation. And then henceforth, screw bone interface, the screw bone interface weakens and ultimately can fail, as depicted in D. We could fix that by having an intermediate point of fixation so that the entire implant moves together and henceforth isn't exposed to the forces of translation and rotation that occur when there is no intermediate point of fixation. And henceforth, failure ultimately occurs in many of these cases. Again, we can prevent that by finding intermediate native vertebral bodies that we left and place screws into them. We could also do a ventral operation and a corpectomy and use a posterior approach to provide the intermediate points of fixation. As I will get into in a little bit, this takes away one of your major ways of correcting deformity, and that is bringing the bone to the implant. And it also requires 2 operations, and the patients that require these operations are often infirm or frail, and 2 operations stresses their system quite a bit. Okay, now I'm going to take us on my journey. Cervical spondylosis manifests itself to us as the surgeons in 2 ways predominantly: myelopathy or radiculopathy and deformity. Cervical spondylotic myelopathy is an encroachment and tethering problem, and it's a result of repetitive trauma to the spinal cord. These patients all have a cervical deformity. They have 2 things in common. The first is the kyphosis trapezius sign, where we see the trapezius muscle, which is an accessory muscle of neck extension that is not ergonomically placed well to achieve extension. But if the patient cannot extend the neck because they have a fixed deformity, or because if they have weak erector spinae muscles, the trapezius muscle is reflexively activated and henceforth can become a source of significant myofascial pain. But these patients all have back pain as well. Here is an example of such a patient who had an occiput to thoracic fusion for reasons that were unclear to us. But here she is with the kyphosis trapezius sign, and look at her posture. She is, her plumb line falls way dorsal to the lumbosacral pivot point, and henceforth there is a significant extension of the spine that must be achieved for her to look forward. Henceforth, the facet joints in the lumbar spine are excessively loaded. And here you can see a lady with the same thing. She's got a upper cervical kyphosis, and in order to look forward, she's got to bend her knees and arch her back and shift the axis dorsally considerably. So in correcting these deformities, we can use non-operative strategies that include posture. The first thing you tell an ankylosing spondylitis patient is please don't use pillows when you sleep, because they're going to exaggerate your flexion deformity, even in spite of the fact that it may make you more comfortable. And we encourage them to do exercises. This perhaps is the most important, to strengthen the erector spinae muscles in patients with significant deformities. And although in very ill patients who are not candidates for surgery, I have not seen a correction of the deformity. I have seen patients who have reduction of symptoms by virtue of doing exercises aggressively. So surgical strategies. We know, this is work from Gogolwala, that if we correct the SVA, cervical sagittal vertical axis, we keep it under 13, 14 millimeters. The SVA is the distance between the C2 plumb line and the C7 plumb line in the standing position, that we will have much better health-related quality of life outcomes than if we don't correct it. And so if we end up with a 45 millimeter SVA, we are likely to see very poor health-related quality of life metrics, predominantly neck pain. So here's a patient that I failed. This is a pre-op flexion and extension X-ray. And I did this operation on her. And her myelopathy improved significantly, but she's unhappy because she has persistent neck pain. I did not achieve the amount of lordosis that I could have achieved preoperatively. And so I beg all of us to aggressively attempt to get the patients back into a good posture with an SVA under 13, 14 millimeters, if possible. Dan Rue, in his Bivector Technique, uses this strategy with Gardner-Wells tongs and two different ropes, one rope going straight out and the other rope going up in order to correct deformity during surgery. And so here's the upward rope now being attached over the bar of a Jackson table down to some weights on the other side. This makes me nervous. In spite of the fact that there's a fail-safe here, the head moves around a lot, particularly when dissecting, and it's sort of like a bobbing spine as we operate. And henceforth, I'd rather use the 3-point fixation with the Mayfield or equivalent head holders, and then repetitively, perhaps, maybe 3 or 4 times, go back and try to gain extension of the cervical spine as the spine relaxes in between times. It takes patience to correct cervical deformity. So why correct deformity? To diminish neck pain, improve myelopathy, decrease end fusion degenerative changes, and improve short and long-term success. It is, we can use ventral or dorsal or combined approaches, and it's truly all about leverage. One of the simplest things we can do is to use cast bar pins. I mentioned applying a bending moment earlier. This is an applied bending moment, putting the screws in a convergent manner and then straightening them out helps us correct a deformity. I also address through the implant.
Ed, can I ask you one quick question?
Sure, I'm sorry.
Going back to what we were talking about before, are you going to talk about cervical parameters and T1 slope and cervical lordosis and how they're related?
Yes, I am.
Okay, I won't say anything else then.
Okay, you can talk all you want.
No, I was just gonna just tell people that I always pay attention to the T1 slope because that'll determine how much lordosis you need to get.
Right. I'm gonna address that with a couple of cases.
Okay, I'll just.
So we bring the bone to the implant here. Here's the picture of that. You serially tighten each of the right and the left screw and convert a kyphosis into a lordosis, as depicted here. We use gravity. The weight of the head is about 10 pounds. In the supine position, we can take advantage of that and use the phenomenon of viscoelasticity, which is the gradual deformation of a body, in this case, the cervical spine, when exposed to a constant load. So this is a 72-year-old lady who's undergone multiple ventral and dorsal operations. Greg, you have something? No, okay. But multiple ventral and dorsal operations and a kyphotic deformity. She's got the kyphosis trapezius sign and again, a progressive myelopathy. She really has no place along her course here, the spinal cord, where there is significant compression, and there's a signal change in an area where there's very little compression. So I want you to keep in mind, this is the beginning of my clinical journey. And I saw this patient 20 years ago, and we all know now what we didn't know then. So I knew we could correct ventrally because her facets were not ankylosed. So you can see this extension X-ray. She's fish mouthing just below the fusion. And so we put her on an operating table with a cushion or a donut under her head and it rolls under her shoulder, and began doing our dissections, et cetera, relaxations, discectomies. And then we took the pillow away and allowed the head to gradually extend. Then we used trapezoidal bone grafts and brought the bone to the implant and converted a 15-degree kyphosis to a 5-degree lordosis. This isn't perfect, but sometimes almost perfect is good enough when the cost of trying to get even more is significant. And I don't mean cost in dollars and cents, I mean cost in morbidity and potential mortality. And it's all about leverage. So if we're doing the cases prone, adjust the head holder over and over until you achieve this, and don't be satisfied with this. I would like you to look at what this patient here looks like at the C2-3 disc space angle, which I'm going to address in a bit. She's horizontal to the floor here. That's where you want her to be. Look where I put her C2-3 disc angle. It's at a downward slope, if you will, in the fused position. Fixation follows. Okay, here she is post-op. First of all, we have her well decompressed. Second of all, her signal change went away. So she improved significantly clinically in all aspects. Her myelopathy improved, her neck pain improved, and she was very happy. So here's the way she looked pre-op and post-op, and we say, we're glad she's better, let's just move on. So we thought long and hard about it. It wasn't too much later that this fellow came in, 68 years old, who'd had a laminectomy 10 years prior for myelopathy, and he improved. now his myelopathy is returning, and he has wide open spaces on his MRI scan. How are we going to deal with this? Is this some sort of a neurodegenerative disorder or what? Well, if we go back to the beginning of my talk here, we talked about cervical spondylotic myelopathy being a manifestation of repetitive trauma and tethering or distraction. So if we extend his spine, or he extends his spine, he moves at every level, but he can't extend past this point due to arthritic changes in his facet joints, but he can most certainly flex well. So Lee said, let's get a flexion extension MRI. And here's his flexion view. So every time he flexes his spine, he severely compresses his spinal cord. And this may be a picture of a post-laminectomy membrane that people talk frequently about. So here's extension or neutral, and this is flexion. So we knew we could fix him dorsally, as I mentioned before. And so we did facet osteotomies at multiple levels, and then instrumented him and fused him. And we pounded our chest and said, this is good. He was happy, his myelopathy improved. But he came back later with this. He topped off at C23. So first of all, we didn't know and didn't achieve a horizontal C23 disc space. Second of all, he had 2 operations at which the C23 facet capsule could have been injured or disrupted to some degree or another. But we also have a long construct going up to C3, and henceforth C23 failed. So he underwent by his primary surgeon this operation. It's very difficult to get correction at C23 when you have that type of a deformity from behind, but he was actually very happy with this, in spite of the fact that his C23 was still sliding downward, but C2 was included in the construct. And I think that's a very important variable that we will talk about in a bit as well. So I have a very low threshold to take a fusion up 1 level. If I only really need to go to 3 and it's a long fusion, I will take it to 2 almost automatically to eliminate this problem. And you lose very little rotation and flexion extension. So here's another fellow who presented with a C7-T1 herniated disc from trauma, and he had an operation elsewhere and had this device placed and then taken out because he had neck pain. And he had neck pain because this is his posture. This is MRI, no myelopathy or anything. This is what he looks like. He's got a positive kyphosis trapezius sign. Some people call this the cobra sign, looks like a cobra's neck. And he's also got back pain, as you can see how his increased lordosis in an attempt to look forward. So we did multiple level facet osteotomies, took down his old fusion, and then flipped him over, combined approach, and did multiple level discectomies, used trapezoidal fibular strut grafts that I formed myself, and then a multiple level construct where we were allowed or able to bring the bone to the implant. And so here he is pre-op, and here he is post-op. Clear improvement, if not complete resolution, of his kyphosis trapezius sign or cobra sign. Sometimes we need to correct at a different level. This is a lady with an ear-on-shoulder deformity. She has neurofibromatosis, ectatic vessels, and a slight scoliosis in the thoracic spine, vertebral artery ectasia. An old clamp was placed here. So she's got an occiput to C2 fusion, which is solid. And here is her head tilted onto her neck Here you get a feel for the amount of tilt of her head based on this coronal CT cut. So here she is pre-op. So we decided that it's best to stay away from the pathology at the occiput to C2. There's just a significant amount of bone here. And we started doing osteotomies from C2 down to C6. And I then went below the table and moved her. We started with her head tilted like she normally is, and then I straightened it out so that she was looking straight forward. And then we finished the osteotomies. This one here, when we did it, actually was associated with a auditory pop. So I bring that up because the patient should be aware, and the surgeon should look for any potential reasons that the vertebral artery could be injured with such a case, because suddenly stretching the vertebral artery over an osteophyte or something like that could have very hazardous consequences. So here is her post-op, intra-op, post-procedure intra-op picture. And the radiologist's report on this was quite humorous, talking about screws going every which way. And I explained to the patients preoperatively that we need to take advantage of the anatomy that's presented to us. And sometimes the fixation postoperatively can have a odd appearance. Here is her picture post-op and pre-op, and she was very happy. This was actually a cosmetic operation, although we didn't list it at that. She says it's really hard to get a date when your ear is on your shoulder. Here she is in good sagittal balance, coronal balance post-operatively, and she was very happy with this. Sometimes we should stage procedures. This lady had multiple ventral and dorsal procedures, had a progressive myelopathy, and this CT scan, and for obvious reasons, we did not feel it was a good idea to operate on her ventrally. So we took her to the operating room and performed laminectomy, facet osteotomies, and felt we could not get a good correction. We really could only see down to C2 or halfway down C2 because this was in the pre-O-arm days. And so we took her back upstairs and we put a log roll under her shoulder, put her into extension with slight traction with Gardner-Wells tongs, and got another CT scan 4 or 5 days later. And we see here that we've got good correction, and we said, we're going to take this. So we took her to the operating room and fused from C2 to T3 or T4. And please excuse me for having crosslinks here, but this was in the day when I used crosslinks. I think they're unnecessary today. Having said that, we used viscoelasticity, gradual creep of the spine and deformity correction over time. Here she is preoperatively. Here she is in the CT scan in between operations. So this is what I mean by a facet osteotomy. You go all the way through, not 99%, but all the way through, and make sure you stay dorsal to the nerve, make sure you've checked your preoperative anatomy for anomalous vertebral arteries, etc. And then if you stay dorsal to the nerve, the artery is always ventral to the nerve. And then here she is post-op. And here she is clinically post-op. She was happy. So we did a study looking at a large population of patients undergoing cervical fusions and looked at the effect of the C2-3 angle post-operatively on outcome. And all of these parameters were statistically significant when we inadequately corrected the C2-3 angle. The reoperation rate was higher, pseudoarthrosis rate was higher. There was progressive kyphosis, adjacent segment degeneration, and disease. So Greg Trost mentioned the C7-T1 slope. This patient is actually in most of the subaxial cervical spine in a lordotic posture. And yet she has a profound sagittal plane kyphotic deformity. So if we look at the C7-T1 angle, or the T1 slope as it's called, and it's significantly angled downward as depicted here, we are dealing with essentially a cervical thoracic C7-T1 and below deformity. It's really not a cervical deformity, and we must address it accordingly. So I use the C2-3 angle for intraoperative utility. It also tells us about postoperatively if the patient has complications or not, or may have complications, but wouldn't it be nice to prevent complications? And then use the C2-3 angle as a barometer or a guide to the extent of deformity correction. So if we end up with something like this, we're going to have a significantly increased chance of having a persistent neck pain problem and a persistent problem with the deformity and changes at the C2-3 space. So this lady previously had a lumbar fusion, but now is complaining of severe neck pain and kyphosis trapezius sign. As you see, she has a positive SVA in spite of the fact that she's got a somewhat of a lordosis. So she has in the upper thoracic spine some kyphotic deformity, which if corrected might make her symptoms better. So we did not attack the cervical fusion that she already had. We simply took out the old screws and put in new ones. But we did facet osteotomies at 6, 7, 7, 1, and then 7, 2, C7, T1, T1, T2, T2, T3. And you can get about 10 degrees, maybe, or at least 5 degrees per level. She did not need a lot, as you can tell. And we used the intraoperative X-ray to look at the C2-3 angle. If you take this X-ray and turn it 90 degrees to the counterclockwise, you can get a feel for what the C2-3 angle is going to be. Now, I emphasize that you're going to lose a little when the patient actually is fused and standing postoperatively. But it gives you a nice barometer to say, I am done. I have achieved the angle, the amount of correction that I need with the procedure that I have done. And so here she is, pre-op and post-op. So interestingly, her C2-3 angle is tilted down. She's almost perfectly corrected with the C2-3 angle post-op. And her plumb line from C7 was relatively normal pre-op, but it's artificially normal because she was leaning backwards in order to see forward. And so now that her neck is fixed, she then gravitates back to what would be her natural plumb line, which is in kyphosis in the lumbar spine. That did not seem to bother her because she had back pain, which was actually improved with this operation as well. If we want to do questions, I could stop here and not cover total disc arthroplasty. Nikolai, what would you like?
Well, I would say maybe you continue because total disc arthroplasty is something that is really hot topic now and has been like that for the last year.
Okay.
So I think it's going to be interesting to hear your opinion on that.
So Nikolai, just so you know, this turns out usually to be the Greg Trost, Ed Benzel Humor Hour.
That I know that, and I know that this is going to be interesting for the rest to see. So I'm looking forward to it.
Okay, so I want to make it clear that I'm just telling you what I see from a biomechanical perspective. I'm not talking about clinical outcome at all. When
I don't have the opportunity to present my arthroplasty talk, so I probably won't say much. I do have an arthroplasty case though in the case section.
Okay.
That's great. That's great.
So motion along which axis? This is a metal on poly disc. It's very rigid, so it transmits loads, and it's a ball and socket joint essentially. So it has very little flexion resistance to flexion and extension, which is quite different from the normal disc. So normally what we'd like to do when a spine looks like this. This is a stress strain curve of a mechanically unstable disc. And the hallmark of that is a widened neutral zone. The neutral zone is larger. It is a sloppier motion segment. So knowing that, we can look at the flexion and extension, or excuse me, the stress and the strain in flexion and extension. It's basically very small with the neutral zone is widened because it doesn't resist flexion and extension. That's just the disc itself. The body reacts to that and stiffens the joint. But is that what we want? I don't know. If it's an elastomeric disc like this Acroflex disc that ultimately failed at the rubber metal interface where it delaminated, it probably looks something like this. If we use a Dynassist system or any other posterior dynamic stabilization device, it should shift the curve back. It should stiffen the spine, but it also probably shifts the instantaneous axis of rotation, which is why these systems aren't associated with significant clinical benefit. And then if we do a fusion, it's instructive to think about the nature. What does it look like on the stress strain curve? Well, it takes a lot of force to create any motion, and so the curve goes basically straight up. So if we look at stiffness in axial loading, I'm sorry about this slide, we see that it becomes, the artificial disc becomes very stiff in axial loading. So it really, in effect, transmits loads to adjacent segments and potentially to the facet joint. This looks about the same as it did with flexion extension, and similarly with the Dynassist system, and similarly with a fusion. So adjacent segments and same segments, we've really got to be concerned about that because it may actually stress adjacent segments. So I'm just going to briefly go through some of the literature that has preceded artificial discs by a long time, the common use of artificial discs, and look at adjacent segment degeneration and adjacent segment disease, which is symptomatic degeneration at a segment adjacent to an index level. So Hillebrand et al. From Philadelphia did a number of studies looking at ACDF and adjacent segment disease, and found that there was somewhere between a 1.5 and 4% rate of adjacent segment disease. Let's just say 3% for the purpose of this conversation after a fusion. Interestingly, a huge study with 846 laminal foraminotomies, the authors from Minnesota in 1983 demonstrated adjacent disease rate at about 3% per year, adjacent to a laminoforaminotomy, a motion-sparing operation. The group from Pittsburgh looked at patients with anterior cervical discectomies with and without fusion and found that there was no difference in adjacent segment disease at about 3% per year in both groups. And then Hildebrand looked at the incidence of adjacent segment disease with multiple level fusions in the cervical spine and found that the annual incidence actually went down, not up, of adjacent segment disease compared to one level operations. I'm not sure why that is, but it is probably related to the fact that if you did the two levels that are most vulnerable to degeneration are 5, 6, and 6, 7. If you fuse one, the other one is exposed to greater stresses. If you fuse both vulnerable discs have been taken out of action. Now, I'm not recommending we do 2-level discectomies and fusions. I'm just saying that that could be a factor, or we may be just dealing with natural history. And there is ample literature supporting the fact that abnormal posture of a disc or a motion segment leads to both excessive biomechanical stresses at adjacent segments, and number 2, increased clinical changes associated with symptomatic degenerative changes. So when we think about this, if we have a kyphotic posture, we're going to be stressing that adjacent C2-3 joint, and so henceforth we should tend to want to correct posture as much as possible. And so 2 discectomies, both of them have great initial postoperative courses. And although I don't know how this patient did, I can tell you that the chance that he will have adjacent segment degenerative changes is much greater than this patient who was left in a kyphotic or lordotic posture postoperatively. And so we should aggressively strive to achieve correction of deformity. Thank you very much.
Ed, that was great, as we were expecting, and you proved that what is biomechanics. This is Ed Benzel, so it was really great. And just to inform you that the decision that we took to continue was supported in the chat, so I have seen everybody wishing please continue. So it was great, and thank you so much for that.
So can I make a few comments?
Yes, I was going to present actually Greg Trost. Greg Trost is somebody that I don't need to present much as well, because he is also very well known to the majority of us. And I am looking forward to hear Greg's comments and what he thinks about this.
These are comments that Ed and I haven't talked about before. I think when we look at the posterior fusion data that Ed presented, we know that a percentage of patients with posterior operations, foraminotomies, et cetera, do go on to have spontaneous fusion. So it's not surprising that they may have more adjacent segment disease than one would expect. About 70% of laminoplasty patients go on to have fusion. And then my other comment about artificial discs is we can't look at the discs in isolation. And Ed alluded to that, but that's a very strong thing to consider because the spine functions as each segment functions as a unit. So the ligaments and so forth and other soft tissues surrounding it may change as stress strain curves. And then the other thing about axial load is that the axial load is probably spread over several segments and not just the level above and below. So I think we have to be somewhat cautious about that.
Can I talk?
Yes, sir.
Please.
So I agree with you. I'm not disagreeing. And let's just use another example. I have a partner at my institution who approaches everything, practically everything in the cervical spine from an anterior approach, does a lot of ACDFs and multiple level ACDFs, et cetera. And I, conversely, approach most of those same patients, would approach most of those same patients with a laminoplasty. He has good results and I have good results. So if Greg Trost uses a total disc arthroplasty and I use an ACDF, surgeons have to understand that they need to do what is best in their hands. And I think this is underscoring that notion.
Yeah, and I think a critical review of the literature is also helpful. And I don't think that anybody would expect arthroplasty to be better than ACDF in the first 5 or 6 years, and that the changes in the literature, and you can look it up yourself, occurs at about 7 years, where the surgery at adjacent levels starts to diverge at about 7 years, and that continues on even through 10 years, where the patients that have arthroplasty have fewer secondary operations at adjacent levels. And that's what the literature shows, and I understand that they're corporate sponsored and all the issues with that.
With regards of this, Greg, there was a very interesting talk presented to one of our webinars by Oscar Alvarez, and he works in Portugal, and we found that in Portugal, actually, the price of the ACDF and disc replacement is one and the same. So this was very interesting to see unbiased decisions, and actually he showed extended use of disc replacement with patients which have a bit more degeneration that I would normally go and do arthroplasty, and he presented good results as well. So this is about the bias of the industry.
Yeah, I know this presentation, but the truth is that in Portugal, arthroplasty costs 5 times more than ACDF.
Okay, well,
in the United States,
not like that by Oscar.
Yeah. In the U.S., in fact, when arthroplasty first came out, the surgeon's fee was something like 70% less than the ACDF. So the ACDF actually reimbursed, so there was no real financial incentive to do it. I also have a couple of patients in my practice now that had arthroplasties done for what I think are less than ideal indications, and they're coming out and having to be reoperated on. So I think that there's ideal patients for one operation and ideal patients for the other operation. And I would urge people to have both things in their armamentarium and use the one that's the most appropriate.
So Nikolai, you said that the cost of ACDF was greater than the cost of total disc arthroplasty. It depends on what you do with the ACDF. I mean, if you put in an expensive plate and an expensive cage, and maybe use BMP or just throw in everything, it's going to be extraordinarily expensive. But
that's also a valid point. Yeah.
But if you just use a simple plate or no plate in resource challenged areas of the world, lower and middle income countries, that operation still works. So we need to take all that into consideration as well. Not all ACDFs are the same.
Yeah.
That's
may
cool.
I make a question to you regarding this, the plating versus no plating? Do you put a plate in every cage, every single level that you use, or just multiple levels? What do you think about that?
Who, me?
Yeah.
Okay.
That's a lot of controversy, a lot of people doing different things regarding plating or not.
I plate all patients because I can, and I use allograft because it's available to us and it's easy. But I use processed allograft. We can also get cadaver or allograft fibula, and if I was really in a cost-saving mode, I would use a sagittal saw and cut my own grafts. But see, a lot of us were around during the era when there was huge controversy with regard to plating versus not plating ACDFs. And people would give talks and be almost thrown out of the room for advocating using a plate. But then we realized that with using a plate, fusion rate goes up, particularly in multiple level fusions, but also in single level fusions. And the plates are in and of themselves not that expensive. So bottom line is, I plate everything.
What do you think about the integrated plates?
And even the...
Sorry, Greg, go ahead.
So the other thing too is that early on, so in my first 2 years of practice, we weren't plating single level ACDF. So this goes back to the 90s. And then there was pretty convincing literature that showed that people had less graft spit outs, that they maintained the alignment that you put them in much better with plates, and that the fusion rate was higher. So that's when it became pretty common practice. People early on in that treatment would argue that, oh no, I don't even put a graft in, or I put a graft in. It turns out that they weren't following their patients very long, and nothing ruins results like follow-up. So I think the use of a single level plating is probably reasonable. And then you get into the question, well, a dynamic plate versus a static plate. And I don't think at a single level it probably makes a difference.
What is your experience with integrated plates like zero profile cages?
I've done a few of them. I think it works. I think it works well because it keeps the graft doesn't spit out and doesn't collapse, which was a big problem. And I think that you still maintain the lordosis that you created. So I think they work.
Yeah. Okay. That's my impression as well. I use a lot of those, and they work well in my arms, in my hands. If I have to comment on plating, so I normally use zero profile for 1 or 2 discectomies, but if I have to go 3, probably I will put a plate. If somebody is a smoker, I know you don't operate that in US, but we still operate in UK. So I would use plate. Let's say if I have to do 2-level ACDF, and if somebody is a smoker, I probably will plate as well.
And I'd probably use autograft if they were a smoker.
Yeah,
they get the punitive hip graft.
Okay, right. Okay.
So Nikolai, are there questions in the chat?
Yeah, so actually there was one question that most of the comments are excellent. Everybody is very happy with the talk so far. There was one question: what is your experience with simple laminectomy? Obviously, it's a good question because we have people from, as you said, low-income countries, and sometimes what we have on our disposal is not available. So. What a multi-level degeneration and laminectomy, simple laminectomy. What is your experience, and what would you say about that?
This is probably going to be controversial. You're saying laminectomy for stenosis?
Yes.
Yeah,
yes.
Laminectomy alone.
Yeah, laminectomy alone is associated with a fairly high rate of kyphotic deformity. I showed several patients today that were victims of that. The second
you consider hemi-laminectomy, for example, instead of full laminectomy?
I have not done that. I mean, I do know when attacking tumors, et cetera, at the cervical thoracic junction, intradural extramedullary tumors, that you can get quite a good exposure with a hemi-laminectomy and then drilling down the undersurface of the contralateral side, leaving the interspinous ligaments intact. I would favor laminoplasty. I think laminoplasty has changed to preserve stability. I have seen several patients who had a straightened spine who actually became more lordotic after a laminoplasty. And I basically was encouraged to try laminoplasty. I was against it for cervical spinalotic myelopathy until one of my partners, Gordon Bell, who is retired now, to try it because he used it quite extensively. And I started doing laminoplasties, and it in my hands for cervical spondylotic myelopathy in an appropriate patient, it is the best operation I have. I feel my patients do the best, so I would gravitate towards a laminoplasty, although you know, doing a hemilaminectomy and drilling off the undersurface of the contralateral lamina does have some appeal to it, but it probably would take longer and maybe a little bit riskier than a laminoplasty. I'm not sure.
So
But
what
it's a decent approach.
Yeah, I've actually did a laminectomy this week on a guy that had, you know, once again, it's appropriate patient selection, had really good cervical lordosis. And it was a short segment. It was only C2 to C4. And someone that was physically pretty unhealthy, so that every extra minute he spent in the OR was not good for him. And the other patients are the patients that have a lot of osteoporosis with an elderly and good lordosis are probably good laminectomy candidates, since even the laminoplasty screws may not hold that well. Once again, short operation, good lordosis, unlikely to fail. And then we know that the rate of developing post-laminectomy kyphosis is about 20% is what people quote. And that the rate of those people, even if they develop kyphosis, becoming symptomatic is only about 25% of those patients.
But that depends also on the configuration of the neck, isn't it? If the lordosis, for example, is 10 degrees, you expect less kyphosis even after laminectomy.
But once again, it's all patient selection and appropriate operation for the patient.
So we know
there can't be one answer to fix everything.
We know that when we do C1 and C2 laminectomies, like for example for Chiari malformation, sorry Atul, but people still use the conventional approaches for that. We know that there's a very low incidence of deformity. And so when deformities occur, it's usually in the lower cervical spine. And so the SU-T3-4 laminectomy is very reasonable. And I've done laminectomies in smokers with lordosis and just made a deal with them. You're not going to stop smoking, and you really are myelopathic. We need to do something. I think it is a viable approach in certain circumstances. But in a low-income country, if you do a laminectomy and then have a deformity, the cost of that deformity is extensive. Is going to be extensive. Implants.
And I think some of this too has to do with the patient's head posture after surgery too. So a lot of people that have posterior neck operations like to tuck their chins down. And if you have that sort of patient, they're going to get stuck there. So you need to educate them beforehand about making sure they keep looking up, because if they end up flexed, they're going to end up developing a bunch of scar tissue within the joint that'll prevent them from extending later on.
That is a very good point.
There is an interesting question here about using autograft over 60-year-olds. Would you want to comment on that as well? This is one question from the chat.
I personally don't know of any data supporting that. The fusion rates are going to be lower, and whoever asked that question, be careful, because several of us on the line here are probably over 60. I've really enjoyed being considered elderly. Having said that, I suppose, but the fusion rate will go down, but I wouldn't think it'd be significant. I don't know. Does anybody have data on that?
No, I personally don't.
I would use allograft if unless the bone quality was horrible, and then you might be wanting to think of some other approach, like a posterior approach if possible, or whatever.
Yeah, well, okay, I think maybe we can get the last.
You do very few ECDFs in a 70-year-old.
Okay. There are 2 points I'd like to make. First is, obviously it depends on who's doing it. So what techniques that you have and how good you're at, and on top of it, what experience you have. So that's important to understand, because I see so many patients operated either anterior or posteriorly and not done properly. So I think that's an important point that you need to be sure, whichever approach you're doing, you need to be good at it. The other thing is that if you've got a relatively poor JOA, and if you are young, then I generally would go anteriorly in majority of these patients, because I can give them better results. And that's what we have shown in a recent study of ours. But that's only for a small number of patients. We're talking about not huge numbers. On the other hand, coming to lower middle income countries, the cost of the plates and the hardware is very low. So we are able to use whichever plate or instrumentation really cheap compared to, for example, if something costs $500 in US, that same thing would be for $40. So I think we may have issues with the cost, but the cost is not a big issue when it comes to the hardware.
Is it the same brand or different?
If you want the same brand, it would be for about $80, $90 or $100.
Yeah,
I think.
Okay.
I think.
What about artificial discs?
Again, artificial disc, unfortunately, because the numbers used are so low, so it's remained expensive, and that's why we rarely use it. But the results clearly are much better if you use a plate instead of not using a plate when you're going anteriorly. There's no doubt about it, and the pain threshold is much better as well. So I think we need to be careful regarding, because you get better fusion overall, and the risk of other graft-related complications are less. So I agree what Ed and Greg were saying earlier.
That's great. So I think maybe because of the time is advancing, I think Paolo wanted to comment on something, and after that, maybe we can just proceed further with the cases.
Yeah, I just would like to add a comment to the laminectomy, because we keep doing laminectomies and they work perfectly well. So again, I think it's a matter of patient selection. One of our master's students for the master's just reviewed some years ago, like more than 60 patients with more than 6-year follow-up on, and only one patient developed a kyphosis that did not require surgery. So probably again, maybe it's the population that may be different. All of our patients have lordosis preoperatively. Most of them have a lot of osteophytes anteriorly. So older patients tend to move less. So of course we don't do laminectomies for patients who have straight spines or have instability or whatever. But for patients who have a good lordosis and a lot of osteophytes, at least in my hands, laminectomy works perfectly. Just a comment.
One additional comment to that, again, it's patient selection too. I mean, You're good at selecting the patients, and the next surgeon may not be. And henceforth, there's still going to be a lot of equipoise here. But one caveat is intradural tumors, particularly intramedullary tumors, have a high associated kyphosis rate without fusion or instrumentation. So I have a very low threshold for instrumenting both.
Yeah, I agree with that. But also on the other side, those patients tend to be younger on one side, and the other thing is that since we are opening the posterior columns, I don't know if this deformity is not also related to loss of proprioception or any other things more than just doing laminectomy. I don't know.
Yeah, so all valid points, and at the end of the day, everything is patient selection, and then number two, whatever works the best in your hands. So maybe it's time now to continue with the case presentations. Greg, do you want to share something with us?
Yeah, I have I was going to show an arthroplasty case. It combines arthroplasty deformity. The other one is just a straight forward deformity that maybe I'll start with. I'll do the arthroplasty second. So let me see if I can share screen. And then
Still can't see you. Usually down in the middle you have
I've got
green
it.
share screen.
Somebody must have upgraded my.
Ahmad, can you help here?
No, this is something on my computer. That I don't know. Can you guys see it or not?
Not yet.
Alrighty, let me.
You can
So
click
on my
share
screen, I
then you
have
can
a
share your
button
screen.
that is green.
Yeah, no, it's a security. It's a security thing. Which is that's all. It's just a security thing. Let me do this once. Give me just a minute.
That's okay. You have Ed, while I was, I'm just going to comment while we are waiting for Greg to share. So hemilaminectomy is, I think Sandeep is quite experienced, and he presented cases doing with tumors with hemilaminectomy in cervical region. I have done a few as well, a few tumors in the cervical region with hemilaminectomy, and I think that they are doing well after that because I feel that doing only hemilaminectomy for tumors or even for decompression, I'm possible to do a good decompression with undermining the midline. And in the meantime, I'm also possible to preserve the interspinal, supraspinal ligament. I'm possible to preserve the muscles contralaterally. The disc is intact, so the ipsilateral facet usually is also intact, or at least half preserved. So the majority of the stabilizers are still there after my operation doing hemilaminectomy. So I think that it is reasonable to do it for cases which require multi-level decompression, like for example tumor. What do I think about that? Am I logic?
Like I said, the only experience I have is with intradural extramedullary tumors at the cervical thoracic junction. And I just a handful of cases, and they did well. And so, yeah, I think it's very reasonable.
Excellent, perfect. So seems like we have.
You should be able to see it.
Yes, so we see.
Just half of your screen.
We see half of it.
Just,
now, if you can show us the other half,
I'm getting there. Jesus Christ, you guys.
No, we would be happy. At the end
show.
of the day, we'd be happy with the half of it, but it's just because you.
I'm going to go skip this one.
Now we are even happier. Thank you.
Thank God. Okay. So this is a 37-year-old lady who's actually status post laminectomy for a section of a spinal AVM. She was actually taken care of by the chair of our department, and she came back to his clinic with her head sort of in a flex posture and complained about a lot of neck pain, really no deficit. He swears he did not touch the facets at all. So she looks quite uncomfortable, really can't move her neck at all. And this is her plain film, and you can see that she's had a C2 through the top of C5, I think 2, 3, 4, top of C5 laminectomy done with actually pretty good preservation of her facets. And so she has this plain film, and then I guess she had repeat MRI, showed her facets were completely, or her AVM was completely resected. Anybody else have suggestions for other studies? And you guys are gonna have to look at the chat because I can't see it.
Well, I'd
So
get
any
flexion
other-
extension views. I'd like to know what the MRI, I guess you got the MRI.
The MRI.
I want to
was-
see if what segments are mobile and how mobile she is.
Okay, so that is her extension film. And her flexion extension look exactly the same as her lateral. So she's basically a fixed kyphotic deformity. And this is only about 10 weeks post-op that she presented. And we sent her to physical therapy and did some things, and she would not change at all.
So like Paulo says, disruption of posterior columns, et cetera, intradural work, there's a huge propensity to this kind of stuff, although this is a quite early and impressive kyphosis.
Yeah, can you see my arrow, you guys?
Yes.
On there? So you can see that this joint too is somewhat open. She's open here, and a little bit open here, and probably the same. I don't know if she's open down here. But I ended up getting a CT scan on her. As you can see, this is her midline cut, midline sagittal, and then this shows her facets. One is left side, one is right side. And any comments?
Yeah, it looks really amazing because it's so short time after surgery. It's basically she developed dislocations on that side, facet dislocations on that side.
Yeah, she's close to perched here and here, and then the facet joints are widened at 3, 4, 4, 5, 5, 6, and then the other side. You can see that she sort of spot welded things here. You can see a little bit of a fusion there, a little bit of a fusion there, potential fusion there, and then widened facet joint here. So we put her in traction, and she was just outright miserable. And so the real question becomes, what do you do with something like this?
It looks like she's almost like spot welding in a couple of places. Like there's like she's starting to fuse.
Yeah,
So
2, 3, 3, 4, 4, 5.
Yeah, I would approach this by way of a posterior approach with aggressive osteotomies, facet osteotomies, and place implants and see what kind of correction I could get. If I couldn't, I would turn her over and do ACDFs and disrupt the joint, get as great extension. If it looks like I can get extension, I might put an implant in. If I can't get the extension that I truly want, I might take, by that time, it's going to be kind of late in the day, I might take her back and put her in traction again, although she evidently doesn't like that. But, I'd do a back, front, back, basically.
Yeah, so I went, any other options? I know people say, I'll go from the front first. People always talk about this. And I think after years of interacting with Ed, all my cervical deformities I do from the back first. I always start posteriorly first. And that's because the posterior release is certain when you get there, meaning you do the facetectomies, you can follow the route all the way out. You can see there's nothing left in place. And then you know if they don't correct, that whatever more correction you're going to get, you're going to have to get from the front.
Yeah.
Greg, did you try to put this patient lying in a horizontal, like supine position, and see how much she will actually correct herself because of the well-known viscoelasticity that Ed is talking about?
Well, she was anytime you try to extend her head, she would scream in pain. So we actually, once we gave her general anesthetic, we tried to extend her, and it did not move, not at all. And in fact, when I got done with the osteotomies in the back, it didn't move at all either, and it was stuck. So we ended up going to the front on her. And you can see that she's pretty thin, which is really unusual for my patient population. There's usually a lot more soft tissue on the people that I operate on. So there's got to be something going on here. And then the other question I'm going to have for people is how long on the back and how long in the front?
So I think that what you just said maybe is answering one of the questions, which approach. If you put the patient supine while being anesthetized, and if the patient was not correcting, and if you did osteotomies and the patient is not correcting, then this is the answer of one of your questions. So you have to go first back, you have to release, then you have to go front, release, and then you have to go and fix from the back. That's probably the most.
But the important thing is you have to get the correction you're going to get from the front. Once you've released the back, it's not likely.
That's also true. So you have to. That's.
Yeah, the posterior approach, the release is certain. I mean, you know it's released if you're looking at the nerve root go all the way out. And usually before I do the release, I will pre-place my screw holes for my lateral mass screws, so I make sure I don't destroy so much bone that I can't get a screw in there. The question is, what levels do you do from the back and what levels from the front?
So I think maybe.
How long would you go?
From the back, I'll probably start from. I think probably I will start from C2, and I will go all the way down to. Let me see, what is that? 2, 3, 4, 5. I think I will finish at 6 on the back.
Okay. And then what levels from the front?
So
can you show us the ones in which we can see the front?
Yeah.
You can see the body space.
I'm afraid that.
So I think maybe 3, 4, and 4, 5, and I will think also 5, 6 from front probably.
What about 2, 3 since you did it from the back?
2, 3 probably I will just leave it for correction from the back, because to my eyes this looks like not very bad.
Yeah, I would tend to go to 2, 3 again. Also, probably if I was able to get there. Also because there is you can see some subluxation anteriorly. The slope, the C3 slope is very steep. So yeah, it depends on the position, intraoperative position. But
yeah.
And what would your anterior operation be?
How would you? Sorry?
Yeah, what would you do in the front? Corpectomies, discectomies, anything?
No, discectomies, just discectomies.
Same for me, discectomy, and I might plate as well.
Yeah,
Okay,
because there's nothing in the vertebral body. So, and I think the likelihood for fusion is, at least in my hands, is higher with multilevel ACDF than with corpectomies.
Here, I think your fusion is better anyway, because she's just pouring out BMPs, it seems.
Well, yeah, and if you talk about posterior instrumentation too, posterior instrumentation should be thought of more as a holding device and not a correcting device, because I think the screw strength is not quite as good, and in the front you can get pretty good long screws, and I usually just take and measure the depth and subtract 2 to 3 millimeters, and that's the length of my screw that almost gets you all the way to the back of the body. Ed, would you do a 2, 3 ACDF on this in addition to 3, 4,
probably
4, 5,
not.
5, 6?
I'd be worried about dysphagia. I'd do a 3, 4, and 4, 5 ACDF, and if I could get great extension, I'd plate. But if I couldn't get extension, if I didn't correct well with a deformity operation, I wouldn't put a plate in, because you're now going to go to the back and want to get more.
Yeah, so I essentially did the facetectomies 2, 3, 3, 4, 4, 5, and 5, 6, and it really didn't move. And when I went to the front and did the discectomies, I'd get the disc spaces to distract, but nothing would really move. So the way that I achieved the correction was to actually fix the terminal points of the plate, and then use the plate to draw the other vertebral bodies up, being careful not to try to get too much out of it. And this is an old case, so this is essentially what I did, and got her in a reasonably good position. Her C2, C7 plumb line is pretty good. She's straight, I grant you, but that's about the best I was going to do. And I was always taught that the enemy of good enough is better.
Mm-hmm.
And I
So
had
you
seen
pulled
considerations.
so you pulled the C3 and the C4 and C5 vertebral bodies to the plate, correct?
Correct. And I was careful because I didn't want to overstress the screws. So that's my point about the enemy of good enough is better. And I already knew that her C7T1 slope or C7T1 slope wasn't very high, that I could get her 2-3 disc space pretty parallel to the floor, and I was going to fix it from behind anyway. So that's that one.
Oh, great result.
So, yeah. Well, let's see here. You guys, it's 10:27. Do you have a quiz or something you want to give here or not? Do you or don't?
No, we just have multiple choice questions.
Alrighty, because we're supposed to be done in like 2 minutes.
Yeah.
Okay. Do you want to just quickly show it, and we can keep discussion for some other day?
Yeah, I can quickly show it. This one's not so easy.
Imad, have you got the quiz ready?
Yes, sir.
Okay.
So this is a 52-year-old lady who basically didn't have much in the way of myelopathy, but certainly had radiculopathy that the treating surgeon thought was related to 4-5 and 5-6. And then the question is, in that case, what's the best operation for her? And he decided to go from the front.
How
because
old
of
is she?
time, out 50, 52, 53, pretty active.
Do you have more investigations?
No, she's not my patient at this point.
So it's radiculopathy, right?
Yeah,
MRI?
cervical radiculopathy. I don't have the MRI either. I probably do. I didn't put it in here.
Okay.
Let me just see once. It may be here. It may be. Yeah, there's her MRI originally. So stenosis, some 4, 5, 5, 6. Roots has a disc. It has this disc at 4, 5. Pretty collapsed disc spaces. Not great lordosis at 4, 5 particularly.
I would go for a two-level ACDF and plate.
I agree with you, Paulo. I'll probably go there and I will try to put big cage and I will plate as well.
Yeah, so that's not what happened. She had that done.
Okay.
Okay, so it's not my patient yet. She did fine for a while, and then developed worsening neck pain and some C6 radiculopathy. And her treating physician got this. They were not too bad looking, and then ended up getting this.
Ooh.
About 3 months down the road when she started complaining about arm pain.
And this is a problem now because this is difficult to revise.
It's a problem. Yeah, yeah, it's a problem, and the treating doc said I have no idea what to do. So he
That's
sent
even
us
a bigger problem now.
Was this because of Flexion X-Ray or?
Well, that's just her lateral. So this is flexion and extension. So it basically just stays the same. And he ended up getting a CT scan on her, and it looks like that. And then you can look at the joints, and you can see that at 5, 6, it looks like it's potentially fused. The components are still where they were initially. It's just that she's completely dislocated the implant. The concern that I had was I didn't know where the polyethylene core was with this lower level, and what to do about it. Usually, that polyethylene core sits on it's sort of H-shaped and sits between these little things coming off the end plate. All right. So now she's my patient. And oops, probably didn't show the final result. No, I pulled the wrong one in here. But essentially what I did was I was worried that trying to just go posterior and try to relocate this was not going to be possible. And I actually went posteriorly and released the facets. And she didn't want either one of her arthroplasties anymore. She said, just get them out. So we released the joints posteriorly at 5/6 and really didn't move. And then flipped her over and we were able to pop the super implant off and the inferior implant off. And then she started to reduce with just a little bit of time and a little bit of distraction. She eventually ended up with basically normal alignment. And I did go back in the back and do a posterior fusion with it.
Okay.
And she
So
actually
you did not.
With the case.
You did not do corpectomy here.
No. The implant actually came up pretty easily here. And once we released her posteriorly, you could distract her a little bit and you could actually see the polyethylene core that was sitting along the bottom.
So you went back, osteotomy, then anterior relief, and then posterior fixation.
Yeah, I fixated from the front too. I put grafts
okay.
in and plated the front,
Yeah.
and then just added the hardware posteriorly because of the dislocation.
And sorry, how long after the primary operation this has happened?
About 10 months.
10 months. Okay.
Yeah, she was well. I think it was in January that she presented to him in August, came to see me in October.
Okay.
He basically told her, oh, this is stable. I mean, bilateral lock facets really are stable because they don't really move anywhere. But okay.
Right, great. So thank you so much, Greg, for the great cases as usual, and really, really good comments from everybody. Now, time for the quiz. Okay, so the first question we have here, one of the most common scores used to assess functional status of patients with myelopathy. Your turn, everybody vote. And the
Looks like they voted already.
We already have the answers, right?
Yes.
We already have the answers there. Right?
Yes, the winner of the vote is modified JOA, and this is the correct answer. Okay, next one. So one of the most common.
That's the same question.
That's the same question. Okay.
Matt, can we move up,
Next
please?
one. Right, cervical myelopathy occurs typically when the diameter of the cervical canal probably is less than what? The result here, the winner is with 45% B, and I think probably we have to go a bit less than that. So
I would
maybe,
say.
yeah. So maybe A would be a correct answer.
Or maybe even 8 millimeters is even a better number.
Yeah, this is critical. Yeah, so it's 8 and below. Below 8 is really critical. Yeah, that's in my box as well.
Yusuf, can you give us the answer? Okay.
Okay, so hyperintensity within the spinal gray matter on T2 imaging is a marker of what? So we have here poor outcome, good outcome in stability and tuberculosis. Obviously, the answer is A. When you see
it's actually none of them. To be honest about it, because the finding on MRI that's more critical is hypointensity on T1. That's the primary indicator of poor outcome.
Yeah, okay.
Yeah, that's more important than T2 hyperintensity.
Yes, I agree with you. However, T2 hyperintensity is also a marker that suggests that something bad's happening with the cord. And
but it's not an indicator of poor outcome with surgery, though.
What the studies have shown is that if the scan MRI is done at admission, then T2 hyperintensity is a marker of poor prognosis, but for people who when it's done late, T1 hyperintensity obviously is a better marker.
Yeah.
Poor outcome is a relative term. If you're a brain surgeon, you know, people being hemiplegic but talking is a good outcome.
Okay, right. Fourth question, contraindication to posterior approach in cervical myelopathy. So we have the majority voting kyphotic angulation. I agree with that. What about the rest of you?
Oh, that's what, depending what you are calling a posterior approach. So if you are talking about a posterior laminectomy and fusion, a kyphotic angulation is, in fact, is a good indication for that.
Okay.
So if you are treating a deformity, right?
Okay, right. Okay, that's a good comment on that. What reflex is said to be a pathognomonic for cervical myelopathy? So we can see here that the majority have answered Hoffman. I personally would agree with that, but in my battery, inverted radial reflex is also something that I use, and inverted radial reflex is known to have over 60%.
Well, I'll tell you, when you go through medical school and you first learn to do Hoffman's reflex, there's a lot of people that have a positive Hoffman's reflex that don't have cervical myelopathy.
Yeah.
That's true. That's true. That's why I said about 60% is not, nothing is 100% in the real life.
It's a constellation of symptoms.
Yes.
Signs.
Yeah. In medicine, talking about pathognomonic sign is something that's really difficult to say.
Yes. Yes, that's true. So it's really, we have to see the whole picture, but yeah, definitely these reflexes are helping. And if I see these reflexes like Hoffman, Babinski, inverted radial reflex, my threshold to believe that there is myelopathy is lower, but definitely.
Or they could have ALS, they could have B12 deficiency.
Yeah.
They could have all sorts of stuff.
Yeah, we have to collect the whole pieces of the puzzle, obviously. Okay, so I think that's the last one, isn't it? So great session, and thank you so much for the great talks and the cases, and for the participation, everybody. This is the next one that we are planning. That's going to happen on 10th of the 10th. That is Saturday, unlike what we normally do Sunday, but this one-off will be Saturday. And we will have Rick Fessler, and we will have again Paulo presenting, moderating. So as we have announced already, you can start sending your cases. This is again something that I would like to remind you. Imad, do you want to flash this slide again?
It says Sunday.
Sorry?
It says Sunday, but it's Saturday. That's so?
That is Saturday, yeah. So if it says Sunday, it has to be amended. So for our members, we have now they will have opportunity to send cases to us, and after scrutiny, we will select 3 of the cases which were submitted, and whoever has sent this case will present the case, and then we will comment on them next time. So please.
They should focus on MIS cases then.
Correct. So that's what I was going to say, that as the next topic is on MIS, please try to send us MIS cases.
Okay, brilliant. How about everybody, if you switch on your videos, we can have a group photograph. And in the meantime, Ed can say a few words before we wrap up.
Well, you're not going to get everybody on this.
Can we switch on the videos, please, everybody? Yep, switch on the videos so that we can have a group photograph. Thank you. Okay, guys, few more. Yep. And Paulo, you want to say a few words before we wrap up? And Saud has to say something.
Yeah, no, just to thank everyone for joining and for participation and for putting the questions in the chat. Some of them, unfortunately, we weren't able to address, but definitely we will have other opportunities to go through it. Thank you, and don't forget to join for next session.
Brilliant, Greg.
No, then thanks everybody for coming. Thanks for asking me again, you guys. I haven't done this for a while. I enjoy it.
It was great to have you.
We have
Always a pleasure having you, Greg.
Yeah, he should be a regular here. We need to make sure of that. Saud, you want to say something? You're unmuted. I don't know. Saud Obad.
Yeah, I'm here.
He was busy taking a nap.
I enjoyed every moment. I started in my office and then in my clinic and then in the car now going to the other clinic, but I enjoyed every moment.
Okay.
Okay, brilliant, everybody. It was really a pleasure to have Ed here, and hopefully we're going to have more fun in a fortnight. Thank you, everybody. Bye-bye.
Okay. Thank you.
Thank you.
Thank you
Bye-bye.
very much. Bye-bye.